This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. Coming up this week is a first time for Blood and Cancer. The whole team's here. The Space Jam, the monsters are here. Dr. David Henry, the editor-in-chief of MDH Hematology Oncology and the executive producer, recorder, writer of the Hard Questions column and Clinical Correlation. Dr. Ilana Yurkiewicz is here. We're all here together for the first time. Dr. Yurkiewicz, welcome to the late night recording session.
Thank you. I'm so happy to be here with you guys. I always listen to the interview portion separately, and I'm happy to be here real time.
So Dr. Henry and I are in Philly, but you, I guess, are about 45 minutes away from a gorgeous California sunset out in Stanford, yeah?
That's right. I'm in Palo Alto.
And Dr. Henry, how are you doing tonight?
I'm very good, and I'm just sitting here very jealous. So I'm trying to imagine that sunset. Sounds very nice.
So coming up later, the reason the team is here is because we're going to have a conversation about difficult conversations. We just did the three-part series hosted by Dr. Yurkiewicz with our two medical student, or I guess residents. I make that mistake every time. Dr. Ronak Mistry and Dr. Emily Breyer. So now it's Dr. Henry and Dr. Yurkiewicz are going to talk about, what's the topic tonight, Ilana?
So we're going to be talking about delivering bad news.
Bad news.
Yes.
It's going to be heavy. That's going to be coming up in just momentarily. But before we do that, I would be remiss if we don't take a look at what's going on this week in oncology. This by Susan London. Immunotherapy enables nephrectomy with good outcomes in advanced RCC. So some patients with advanced renal cell carcinoma treated with immune checkpoint inhibitors can safely undergo nephrectomy and experience favorable surgical outcomes and pathologic response. This is according to a cohort study published in Urologic Oncology. The investigators undertook a single-center retrospective cohort study assessing outcomes of 11 nephrectomies, it's 10 radical, 1 partial, in 10 patients with advanced renal cell carcinoma. And, of course, you can stay abreast of all things hematology and oncology at mdh.com/hematology oncology. Dr. Henry, this is just more uses for immunotherapy.
Yeah, and this is interesting. I can't wait to read it in full because for years, we used to just diagnose the renal cell metastatic, and there was this early data that if you take the kidney out, which we typically don't do when things are metastatic, then the metastases would get better, patient would do better. And of course, this was tough on the patient who's not feeling well, metastatic, et cetera. And then there was a plenary session at ASCO 1-2 years ago that actually randomized patients to get nephrectomy or just an oral agent, a TKI. And the results were similar, which of course spared the patient surgery. So now, fast forward to now and all this immuno-oncology revolution, sounds like this is talking about pre-op immuno-oncology antibody, get a response where this is approved for renal cell, and then consider taking the kidney out or not. So sounds like good reading.
Yeah, I remember hearing this in 2016, 2017 ASCO and different meetings that the late stage uses of immunotherapy were just the tip of the iceberg, that the neoadjuvant setting and different uses for it were what the next 20 years were going to look like. And I think this is an instance of that exactly happening.
Yeah, I agree.
All right. So that is This Week in Oncology. You can find a link to that story as well as a link to the homepage in the show notes. The Hard Questions column is authored by Dr. Ilana Yurkiewicz, where she gives us the human side of hematology oncology verbally in clinical correlation at the end of every episode. Coming up next, we're going to have a conversation about delivering bad news with Dr. Ilana Yurkiewicz and Dr. David Henry.
So stay tuned to hear about talking us to each other.
Welcome back to Blood and Cancer. I am Nick Andrews. It's time now for the conversation portion of our episode. The Dream Team is here, and it's a heavy topic as it always is, but Dr. Yurkiewicz does such a great job of removing herself from the situation and making observations and leading conversations that are difficult to have. So without further ado, why don't we let the oncologists get to talking, Dr. David Henry and Dr. Ilana Yurkiewicz.
So here we are. We've enjoyed listening to Ilana so much after the interviews that I've been doing on Blood and Cancer, and we're delighted you're able to join us on this Blood and Cancer podcast, which you can also see online at mdh.com/hematology-oncology. And at the end of every podcast, there's one of our residents at Pennsylvania Hospital dutifully does these show notes. So you can look to the bullet points if you want to see it as well as hear it. So I've enjoyed so much listening to Ilana afterwards. I thought, well, why not get her on forwards instead of afterwards? And so today, Ilana Yurkiewicz is with us from Stanford, where she's a senior fellow training in hematology oncology. Early in her career, I'm at sort of the other end of the country and the other end of the career. And we're going to talk about how to deliver bad news. So Ilana, welcome to this podcast with me.
Thank you. I'm so happy to be here and talk about this really important topic.
It really is, and sadly, but nevertheless responsibly, we all face this and have to do it. And I thought the way you and I could go back and forth on how we do it and bounce off each other is all too often. I must see one a month that a primary care doctor calls and says, gosh, a patient of mine was not feeling well, abdominal pain. I got a CAT scan. And guess what? She has a mass head of the pancreas, liver metastases. We got a quick IR biopsy. It's pancreas cancer. Can you see her this week? And of course we do. And so I'm picturing that you and or I were sitting with this patient, family is there, they're very anxious. I'm going to guess 55 years old, and a family, maybe some children, maybe possibly even grandchildren at this point, and we give the diagnosis and the bad news. So what's your approach, Ilana, to that patient as you sit across the table?
Yes, so this is a very, very common scenario, as you know. As oncologists and hematologists, we're often front line to being the first people to deliver bad news. And then at the same time, we're also the ones being counted on to come up with a plan going forward. So before I get into my approach, I did want to give a shout out to, I don't know if you've heard of the SPIKES protocol, but there was a paper that actually came out in 2000 that I learned during residency that gives this this mnemonic SPIKES for
I haven't. What's that stand for?
For giving bad news. And then I've kind of adapted that over the years, but the S stands for setting up the interview. So things like who will be there, where will you physically be? The P is assessing the patient's and the family's perception, so their ideas of what's going on. The I is obtaining invitation to give bad news. The K is then giving knowledge, giving the news itself. The E stands for emotion or empathy. So you're addressing the emotion, you're making empathetic statements. And then the S stands for summarize and also strategy, which is the plan going forward. And I think it's a great paper. If the listeners have time to read it, and then I've kind of adapted it over the years as I've done more and more of these. And with the caveat that every patient is different, and a lot of this is reading the room and figuring out exactly what the dynamic's going to be. I think my approach is first always the setting, just like in the SPIKES protocol. So making sure, is this the right time? Is the patient kind of open and willing to talk? Are there a million other things going on in the room? Is it really noisy? Is the IV machine beeping? Things like that. It's a good time. It's a good place. And then I ask the patient if there's anyone else who they want to be there, who they would want to be there, while we're having this conversation, so that they can either call in their family members or friends. So the right people, the right place. And then the next thing I do is I ask for their understanding of what's going on. And, people have given me the whole range of answers. Sometimes people know it's cancer and they've already Googled 100 articles about pancreatic cancer. And then on the other end of the spectrum, there are people who are like, well, I know I'm sick, and maybe that's all they know. So that's really important for the provider to know, I think, because then it guides how you're going to frame the rest of the conversation. So I ask them what they understand about their illness. And then once I get that, a good tip that I've picked up from a palliative care doctor is to give a warning shot before you actually go into the content.
Interesting.
So saying something like, I thank them for sharing with me their understanding of their illness. And then I say something like, we're going to talk about some things that can be difficult to hear and can be emotional, but I want to be truthful with you about what's going on, something like that, so that they know that this is a serious talk. We are going to be talking about bad news, and that kind of gets them prepared. So
Focused
you just don't, just don't kind of jump in and overwhelm them with content immediately. And then before I start talking, I make sure they seem okay with that, because if someone gets very emotional, even from that, I think I've talked about this before, that just overwhelming someone with content when they're really emotional, first of all, not kind of the nice thing to do. And then second of all, nothing's really going to stick. So making sure that their emotions are addressed, they seem like they're ready to have a serious conversation. And then if you feel like they are, then the next step is actually delivering the information, and just being very honest about it. And another tip that I would want to, I give credit to a palliative care doctor who taught me this, is don't talk about all the things you can't do, just talk about what you can do. So let's say it's pancreatic cancer and it's not resectable. Don't say things like, well, we could do surgery in some cases, but it's not appropriate here. Exactly. Or we could do, chemotherapy, but it's not appropriate for you because of X, Y, and Z. So just be very straightforward about what you can do. And that goes into having the plan and what the next steps are. And then after I deliver information, I pause, and I often say something like, well, I know I've said a lot, and I know you must be feeling a lot. What questions do you have? And then I try to let them guide it from there. I try not to do all of the talking. I mean, I want to give them the basics of information, but then I want the conversation to be guided by their emotions and their questions, and then we go from there.
Yeah, so I like your mnemonic and your approach, and a little variation on the theme from me, very similar. I'm picturing the patient we're talking about being in the office setting, so usually there's family and friends there, but I'm sure I set aside a proper amount of time. I'm sure I'm sitting down and look, like I'm gonna talk and not just waiting to get out the door.
Yes.
I try and be sure that they're never alone. Occasionally it's true, but you want to be sure family or friends are there, and often they've come with questions written down, which we really like. At the end, I'll just jump ahead to the end of it, which we sometimes see. You've probably seen the daughter or son will go, Dr. Henry, can I ask you a question outside? And you immediately lose patient confidence. Now, the patient may say okay on occasion, but if you now walk outside with a family member, well, you really shoot yourself in the foot, because whatever you're about to say they can't hear must be terrible. So I try never to leave the room. I get a lot about, as I'm talking this out in your very nice approach, I lock on the eyes of the patient, because if the eyes wander away from me, the patient's thinking and nothing. I kind of tread water for a few minutes while I'm waiting for those eyes to come back, and then lock in again and start talking, because they really weren't focused those past few seconds or minutes. And interesting, we'll see what you answer. The patient often in this situation doesn't ask, how long do I have to live? Because I think they're terrified, understandably, what you might say. Many times the family or friends or even the patient say, so this is terrible, how long to live? And I tend to say, well, in Hollywood, you're given an answer and it always comes true because it's the movies. It's never true in real life, taking care of you. And I try, of course, you don't want to lie, and you don't want to over optimistic, overly pessimistic, and try and walk the truth. And so I say, I have therapy for you. And I talk about what the various therapies might be. And if you respond, you'll do better. If you don't respond, people know this is cancer and it can kill. And you have to say, if you don't respond, that's bad news, and that might shorten your survival. But I have something else I can do. And then we bring in clinical trials, always trying to be, just as you said, something you can do. And I'll give my little story now and then hear yours, of an anecdote that taught me early on how never to give bad news a certain way. So we rewind a long time, closer to your decade, when I'm a medical student, senior medical student, and a couple of us thought, well, let's just try this prestigious hospital that's well known across the country, I won't name, and go there and interview and see if we get in. What can they do? The worst they can do is not take us. So we go there. And in these days, long ago, the interviews were intense. I remember it was 11 attendings facing me in a room, and I was sitting opposite the desk, and 11 people, and one led the interview and the other 10 were just looking at me. So that was brutal. And then they said, now we're going to put you guys, there were 4 of us from the same school, in a conference room on Chiefs rounds. So here we are in Chiefs rounds, and in comes a couple medical students, all looking real sharp. And then in those days, interns wearing all white and long white pants and collared shirt, and a couple of those, a resident, chief resident, and chief of the service, whose name I immediately recognized because he was on the masthead of many journals. And this intern comes in and presents beautifully. A patient came in last night, 45, married, couple children, new case of AML, acute myeloid leukemia. In those days, we didn't have great therapy, and he makes a beautiful presentation, closes the medal chart, and says, I told him that this is a very significant diagnosis and probably best to get his affairs in order, and we'll do the best we can for a couple months. And so the quiet chief of the service says, stand up. And the intern looks at him, sir, stand up. He looks at the chief resident, who shrugs his shoulders and says, I don't know. So he stands up and he says, leave this room. And furthermore, you're through here. And you know I'm powerful and connected enough in this country that you're through everywhere. Go. So this somewhat arrogant, well-heeled intern wearing starch white is now sweating bullets and walks out, a bowl of jelly. The students from my school were in the back crossing off this hospital. We don't want to go here. And this is a true story. And what takes a couple of minutes seems like hours. And then he turns to the chief resident and says, go get him. Brings this poor kid back into the room, who stands there in the middle of the room with all these people, other students and residents, interns. The chief of the service looks at him and says, that's what it feels like to have no hope. Don't ever do that to a patient again.
Wow.
And I never forgot. And because it is true, even though the patient we're envisioning with pancreas cancer and metastatic to liver, we know how poor the survival potential is. You can't tell someone they're being shot at sunrise that there's just no hope. You have to tell them that you're there with them, as I try and point out, through thick or thin. I'll always be with you to take care of symptoms and whatever comes our way, and we have some therapy to do. So that worked for me. Did you happen to have any story that taught you a lesson?
Well, first of all, I think that is an amazing story. I'm glad that some things have changed since then.
Yeah, right. Yeah, it's 4 people, not 10, 11 interview. Yeah.
And I think, it does make a really important point, actually, that this is a teachable skill. It's not something that people necessarily come into medical school, residency, fellowship with. And I think we're recognizing more and more that it's not a bonus. It should be part of the curriculum. It's important for every physician to learn in oncology, and it's something that is teachable. So I think that's a good takeaway from your story.
Yeah.
I was going to share, I could share one brief story about bad news gone wrong and then bad news kind of gone right and what I learned from it. But actually, good. I think from the bad news gone wrong, your story made me think, actually, so this is more of a personal anecdote when I was on the patient side. And I it's hard to talk about, but I do think it's important to share, because so when my grandmother, shortly before she passed away, she was in the hospital with congestive heart failure for a long time. And the team had been thinking about talking to my mom and my aunt, her daughters, about hospice, that essentially she was reaching that time. And this was the middle of winter in New York, and my mom and my aunt go into the hospital, and they're still wearing, all their layers, the big hat, the scarf, the coat, the earmuffs. And the doctor just kind of stops them outside the room. They don't even get a chance to sit down, take off their coat, and just say, well, there's nothing more we can do. She needs to go home on hospice. And it really stuck with my mom. It was just a hard enough situation as is, but just, we were talking about setting earlier, making sure it's the right time and the right place. And just, I think the way that was handled was, I just really regret it personally for how it affected my mom. And I think it was a good lesson then for me going forward, is really to pay attention to the setting before you even start talking about bad news. For God's sakes, let someone sit down, let them get their bearings before you have a conversation like that.
So many wrong pieces in that story. And that, I think oncologists as a group do a good, because we sadly have to do it a lot. So we know that this can really go bad if you do it badly like that.
Yes. So as hard as things like that are, I hope they can provide learning points for me and for our listeners, because sometimes what not to do is just as important as what to do. And the story I was going to share about things gone better, and I'll share the lesson from this too. This was pretty recently on the inpatient heme service. Had a patient come in who had a history of ALL, had gone through a lot of chemotherapy, went into remission, but every type of chemotherapy had really nearly killed him. He just had so many side effects from everything, and it was quite the journey to get him into remission in the first place. He comes back into the hospital. He's not on our service. He actually goes into the vascular surgery service because of gangrene of his foot. And right before the surgery, they check a CBC, a complete blood count, and they find that his white cells are 100,000. And initially, vascular surgery is thinking, well, he has gangrene. His white cells are 100,000 because he's clearly infected, and we need to do this surgery, this amputation. and they call hematology, which is us, and we look at the smear under the microscope, and it's just sheets of blasts. So very clearly his ALL had relapsed. And so then he's transferred to us, and we need to break this bad news to him. So I go into the room. He's extremely anxious just upon even seeing me and hearing that I'm part of the hematology team, because he knows that something bad is coming. All he knows is that he was transferred from vascular surgery to us, but he doesn't know the details of why. So that was already a red flag for him.
Yeah.
And I kind of just paused, gave him some time to, to share what he was feeling before I got into it. And I broke it down, gently but honestly, that unfortunately it looks like his ALL is back. And that was the end of our first conversation. He got very emotional after that. I had planned to start talking about treatment options that we can do for relapsed ALL, but I didn't get there. And so I would go back to his room every single day and kind of one step forward every single day. And then finally, after a couple of days of this, we were able to talk about an option for relapsed ALL that he ultimately agreed to after his terrible experience with chemo in the past. And I think this story was really important to me. And I think about this because it showed me that the bad news conversation doesn't need to be one conversation.
Yeah.
And if someone is extremely emotional, understandably, from what's going on, break it down, just stop talking, get out of the room or address their emotions, do both. And it takes time. People will often get there on their own timeline, not your timeline.
Well, I think that's a phrase I'm going to remember. It takes time. I think that's kind of a nice title of what we're talking about tonight, because it's not easy. And, we all have busy clinics, and they're getting busier, and electronic medical records. And, when you come to this kind of room, new patient or follow-up patient, you have to be prepared it takes time. So I couldn't agree more. I think, we've really covered what it's like, what you have to do, a lot of nice tips from you with somebody to help you remember how to do it. And of course, a couple of stories. I don't want to finish without asking you what you're going to do. You're a senior fellow. What are you going to do next year? Do you know?
Well, I have one more year of fellowship, actually. So,
Okay.
So that's what I'll be doing next year. And then after that, so my research is focusing on clinical outcomes and acute leukemias. So I'm doing some stuff with ALL and AML, and then looking for academic jobs in that space.
Will you be oncology only, or will you do hematology oncology as you're looking toward graduation?
Yes, so I will be double boarding. And I think ultimately where my research interests are taking me is closer to the malignant heme side, but I'm also open. We'll kind of see what happens in the next year and see if things change.
And would you say the rest of your class, how many each year in your fellowship program?
So we had 10 our year, and it's usually somewhere close to that or slightly less.
And do you think they'll all be double boarded, or probably not, or mostly?
Yeah, so I believe there's only 2 our year who are single boarding. There was one heme person and one onc person, but at Stanford, most people tend to double board.
I think it's a great skill to have this, speaking from nearly the end of a career as opposed to the beginning. I think practicing both hematology and oncology is really wonderful. And the areas have caught fire with regard to science and bench to bedside, the science translating into therapies that are almost impossible to keep straight, but it's doable. And it gives you a nice ability to take care of hematology, benign, malignant, and oncology.
I do agree with that. Yes, yeah. I think the hard part about academics is feeling like you get narrower and narrower, but at the same time, I think I went into this field because I like all. So still kind of debating the options.
Well, one more question occurs to me. So, when's the last time you bought a textbook? I haven't bought one in 10 years. Have you bought any textbooks lately?
Probably med school. So at least 5 years ago.
And so how are you learning? Of course, you have mentors now, but one day you'll be attending. Besides listening to mentors in clinic and in the hospital, how are you staying up to date besides using up to date? What else do you use as resource to learn?
Journal articles.
Mhm.
I mean, I think that's a big piece of it. The field moves very rapidly, so making sure that you're staying well read and, reading the big ones that come out so you're up to date on everything. And I mean, a lot of it is learning from experts who know more than you about each disease. And I know in fellowship, I feel very lucky that I could always run a case by an attending, but I think I'm also inspired to see that there are young and actually older attendings too who still run cases by each other. And so I'm hoping to be in, a collaborative place like that where that kind of exchange of information is always welcome.
Well, absolutely. I'm remembering very well, and to this day, that the minute you're an attending, you don't suddenly know all. You realize you don't know all, and you call those more senior and by years, or even your juniors. So, and of course, I know you must listen to podcasts all the time to stay current as well.
Yes.
So I think we'll just call this to a close and thank everyone for listening to Blood and Cancer. I've certainly enjoyed talking to our nearly senior fellow, Ilana Yurkiewicz at Stanford. And you can find us online at our online journal, mdedge.com/hematology-oncology. And this podcast, Blood and Cancer, wherever you get your podcast, can be downloaded and subscribed to weekly. And show notes from this evening's today's talk will be online on this same journal webpage. And we thank you all for listening. Ilana, thanks so much.
Thank you so much for having me.
You're welcome.
And that's a wrap on this episode of Blood and Cancer. I am Nick Andrews. Let's get to the credits. Blood and Cancer is hosted by the editor-in-chief of MD Edge Hematology Oncology, Dr. David Henry. Dr. Ilana Yurkiewicz was our guest this week. She is also the producer, writer, and the voice behind Clinical Correlation. MD Edge podcasts are produced by executive editors Denise Fulton and Kathy Scarbeck. Blood and Cancer is produced by Mary Ellen Schneider. And our social media is produced by Kyla Clark. For MD Edge, I'm Nick Andrews, and this is Blood and Cancer by MD Edge.